Well, had I known it was an alpaca, it would have been a lot less awkward.
With a name like Ricky, how the hell are you supposed to know?
Yeah, I'm not sure. So
That's weird.
yeah. Anyway, so let's jump in. Today is our premiere podcast, episode 1. We're excited to be doing this Back to Basics podcast. The goal for what we're doing is that we're going to talk about medical cases, research, topics in emergency care, and bring it back to basics, right? Like break it down for students, for anybody really, even experienced providers in the field, to be able to go back to the basics and really retain and learn what they need to. Exactly. So today I wanted to talk about this case that you had told me about that you had. So you know which one I'm talking about.
Yep.
So jump in. Tell us about this case, and then we're going to talk about a couple of learning objectives off of this. But go ahead.
So it's a little bit of a long story. All right, I got to give you the background information first.
Background.
So I was working at the department. My partner and I had already responded to a trauma call at a residence. And the victim of this trauma call, I'd never, still to this day, have never seen anything like it. This guy was, we thought, macheted, quite honestly, in the back of the neck. I mean, his head was like 3/4 of the way off, and yet he was breathing and talking. He was actually smoking, laying down on the ground, and smoke was coming out of the cut in his neck when he took a couple puffs.
Wait, he was
of his
actually
cigarette.
he was actually smoking
he
a cigarette.
Lit a smoke, and I told him like no,
almost
we have
halfway
and
decapitated.
My team's looking at me kind of like this is bad. This
Right.
is really bad. And then we just sort of semi-notice that there's a cop in the corner with a long gun trained on the opposite house just behind us. So I'm going, what is going on? So turns out the story behind this, and it was badly dispatched to us and kind of given us this background, but this guy had been assaulted.
Clearly.
Right. This guy had been assaulted with a knife, and the guy who basically lived like kitty corner to him, I think maybe they lived in the same house. But anyway, he's basically kitty corner, backyard to backyard, diagonally.
Okay.
Right now. He's on the back porch. And we find out that the perpetrator of this crime is in the house that's right over there. And there's like cops with, we weren't told to stage. We weren't told. It was just a mess because
Is
the
he
cops
barricaded
didn't know.
or is he just?
So that's what they kind of figured, and they didn't know what kind of weapon he had, which like
Clearly
we'll
had a knife.
We'll get deeper into the story, but like based on his chosen attack style, like if he had a gun, I think he would have shot the guy, right? So anyway, this guy's living and ends up making priority 1 trauma. Obviously, ends up making it, but it was
So that guy does fine.
An immense,
as fine
as far as we know.
Sure.
Yeah, so an immense amount of blood. We patch him up. We have to pull him through the living room. We find out that this is not this guy's residence. He lives with the assaulter, we think.
Okay.
But we're like walking through the living room of this family now, and they're like, yeah, get better soon, like Harvey or whatever his name was. And I'm like, his head's off. Like, you know what I mean? Like we're trying to. So very stressful call. We run a very emotional call. I think it kind of shook the team a little bit.
I feel like maybe you guys are the only one who knows what's going on because
it was
this
rough.
guy is trying to
We get back and we're like kind of shooken up about it. We do a diffusing and all that, and the team's we've already had like multiple CPRs. We had a couple like hangings that week. It was it was like a tough time at that station at the time. So 4 a.m. runs around, and we get called out to stage for now the barricaded guy because they had to go in and get him.
Okay, so he's still there.
Yeah, and so already, like, I don't want to say bias, but like already I have like preconceived notions about this guy because I know he's capable of like slicing someone's head almost all the way off. Yeah. So it's like freaking me out a little bit. But we're called to like potentially treat him, that's a tough position to be in.
Yeah,
you gotta kind of set your emotions aside with it because you saw his victim. But anyway, again, they don't know. I think it might have started around 2 a.m. because it went till, I don't think we cleared until like 6 a.m. when this was all said and done. But these guys have like long guns trained on the house. They're like megaphoning him to like come out. He's barricaded in. And eventually they end up calling in the SWAT team.
Okay.
And I want to preface this with just saying I'm a huge fan of cops. I think especially the cops in the city that I work in, they're wonderful people. They're compassionate people. They're the good guys 100%.
Yeah.
But if you experience time with cops, their training is very different than ours. Their training is to control situations, sometimes more through force. You know, they directly control a situation. Our job a lot of times is to kind of flow with a situation. We don't have to control it. We have to flow with it in order to survive it.
Which is why you're staging in this case, right? Like you're staging there in case something happens to this guy, something happens to one of them, that kind of thing.
So we just have different mindsets though. You know, cops tend to unintentionally, I think sometimes amp things up because they're trying to wrestle a situation to the ground.
Yeah, that's
when
their
we're
role.
more kind of get more and more calm and kind of.
And that dynamic works well, right? You
Absolutely,
need both.
yeah.
You can't have one or the other. You kinda
So
need
right
both.
now we're very outnumbered though. There's a SWAT team here, right?
Right,
So
yeah.
and on a scale of like 1 to a SEAL team, these guys are like Rainbow Six Siege people. Okay, like they're like pretty intense
Yeah, yeah.
dudes. Like the county team comes in, right? So they're telling us like, you got to stage right here because we're gonna go and we're gonna get this guy. And you'd think like watching TV and stuff, oh, this is gonna be a fast process. It's not if you ever stage one of these calls. Like it's
Sure.
hours. They try every means necessary. Like very 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 low risk scenario. Up to, okay, now we're
They don't
busting
just
in
go
with the
barge
big guns.
in.
Yeah, they're
Right,
not just
yeah,
gonna
of
like, hey,
course.
flashbang, like we got you,
Yeah.
rappel from the ceiling sort of thing. So they try all sorts of things. And I could tell, I think some of them were just kind of like excited to use some of their new toys. Like they're using like the fiber optic cables. They had
Sure,
like a little
yeah,
RC
yeah.
car and stuff, and they're pumped. But we can't like be involved in it that much because we have to be set aside and ready to go. So this is like hours long process. So we ended up starting taking shifts. I would sleep in the back. He would sit in the front. My partner would sit in the front, and then we'd swap. And then eventually, all of a sudden, everything just like lit up. They were like, "We got him on the camera. Like we're going in now." We flashbanged. They had tear gassed it.
Okay.
And then they're like, "Go, go, go!" And I was already really surprised because there was a doctor.
So I feel like we should preface, like, for our listeners who are not in these kind of services, because like hopefully we have people listening who, although this is the first episode, so maybe nobody's listening, but that's okay.
That's
anyway,
true, but they will.
But this
They'll
is not
listen to it because it's so good.
because it's so good. All right, perfect. So this is not a typical ordinary call. Like this is not
Absolutely
something you
not.
go
No.
on a regular basis.
I've never
This
ran on.
is-
Like we can even go as far as saying like the trauma call that I had before this,
Right.
that like referenced this call, is not like a everyday thing that
Right.
that you should be seeing, or you're in a pretty messed up city or something.
all right, perfect. All right. So just so everybody
definitely not
realizes
normal.
this is-
Like SWAT teams do not get deployed. Like this
Right.
is like the only SWAT deployment I can think of in my 5 or 6 years at this department. Yeah, and even the call before this, where with the guy with the sliced head
Right.
thing, like I'm not running on like crazy traumas all the time.
those
like
severe
that. So-
traumas. Like you do, but it's not like
I
that.
mean, if
where-
you live in a city where you're running on someone's heads 3/4 of the way sliced off every day, then I would suggest moving.
Move.
and quitting. So, but yeah,
Absolutely.
so no, not definitely an atypical call in terms of the intensity of
Sure.
it. But so anyway, we pull up to the house because we were staging at basically a school down the road.
they've gone into this.
They've gone in
full
and they're
force,
like some of them are in and some of them are out, and they're all like screaming at like, you gotta go, you gotta, which is like hard for us to understand because it's like we knew you guys were going in there with potentially lethal force. Like something happened, we don't know what.
you don't know what, okay.
But so it turns out like we get the story as we're going. It turns out as they kind of busted it and they had tear gassed him, and then they saw him on the camera stab himself in the heart with a knife. Just full suicide, like boom, stab it with a knife.
Wow.
So that's when they went in. It was more like, it wasn't to take him down, it was to help him out,
say,
right?
yeah,
So they rushed in, and they have a team doc that's on that. But the whole place is tear gas, and they're like rushing us. So I'm like, whoa, wait a minute, I'm putting on a mask. Like, I'm not gonna,
yeah.
You know,
You're
it's
not gonna be able
safety
to-
first. You
You're
know,
not
you
gonna be able
gotta
to serve this guy if you
right,
can't
but
see
they're
him.
really like, you gotta go. My partner doesn't get his mask on in time, so spends the entire call crying because he's been tear gassed
Right.
essentially, which was hilarious to me. But we bust in, and what confuses me is that the team doc is already down on the guy, like trying to do CPR on him,
Mm-hmm.
but the guy's got a knife in his heart. I'm not talking center chest. I'm not talking in a lung. It's not like something where it's straight
left
in,
side,
right
right.
in his left side. He knew exactly where to go. It is in his heart.
And I'm
Like, this
assuming that
guy
if
is-
there's a
deceased.
SWAT doctor there, like obviously he's checked a pulse. There is no pulse, like so he starts CPR.
Right. So, and he's very like, again, things are very amped up. I think it's hard for probably someone like you to jump into a stack and rush in and not have the same kind of emotions this guy's having, because like he's now amped up. He's thinking more cop than medical provider, right? So
Well,
I
and
think
even-
he didn't have like the opportunity to like sit back and like analyze the situation and be like, okay, maybe this isn't a recoverable situation. He was just,
Yeah.
it was go because they rushed
Well,
in
and
so
even
quick.
as I said, an emergency physician, I would like that's literally the only thing you're there for is this scenario. So you do want to help that person as much as you can, but again, like we're talking in this, we're
Yeah.
getting this a little bit more, but like, is this even? I mean, what's
Well, right,
our
and
end
we
goal
we
here?
went from not knowing if he had guns, not knowing if again, I think it's kind of obvious that he probably just had a knife, otherwise he would have
Right.
shot that other guy. But
Right.
like we didn't know what he had, sort of thing. So they rushed in, and I'm not a cop, so I can't tell you about like that side of it. But
Yeah,
all
yeah.
I know is when I came in, it was a lot of kind of panicked SWAT team members, SEAL Team 6, Rainbow Six style, like,
Okay, right.
you know, and the doc kind of trying to do CPR and everyone kind of being like, you got to get him, you got to save him, do something. So we grabbed the backboard, and what I tried to do was we loaded the guy up. What I tried to do is have them just set him down in the front lawn or in the driveway so we could like work him there if we were going to work him, because I'm already thinking, I don't really want to put this guy in the back of my ambulance because I think it's a priority for, like, I think he's just deceased. That's not something that
So your
we're
initial
gonna
thought
get
is this
around.
guy has stabbed himself in the heart and now he doesn't have pulses.
Yeah.
He's gone.
Right,
Like,
he's gone. Like, this is
not
going to be a
much-
pronouncement, or this is, you know,
Okay.
and we're going to need to cover the body and things like that. Also, if you put a dead body, if you've ever done this before, if you put a dead body in your ambulance, now the mortician is coming to your ambulance and you're now out of service for hours and hours and hours. So,
Sure,
like,
okay.
operationally,
It's like a logistics
it's
part of it,
wise to, you know. But again, in my mind, I'm like, oh, I'm going to call the hospital. They're going to say, yeah, pronounce him. Like, that's what I thought was going to happen.
Sure.
But again, the SWAT team and the SWAT doc are very like, you gotta do something, you gotta do something. So we end up loading them up into the ambulance. So
Okay.
the door shut.
Are you doing CPR this time, or is that doctor still
The
doing
doctor
CPR?
was doing CPR, and then we got him on the backboard and pulled him off. And I was like, no, halt CPR. Like right there, I was like, halt CPR. We're done here. Like it's not. So we can stop doing. We can pronounce someone right. We'll get to it. We can pronounce someone right then and there when there's like obvious signs of death, like a decapitation. Like you're not gonna like try to sew someone's head back on, right? So like a decapitation, and in my mind, a knife inside the heart that's a non-recoverable instance, right? So I'm ready to pronounce. They're kind of amped up. So just for the sake of them, we load them into the back of the ambulance, and then I call our local hospital. So we operate with kind of two local hospitals. One is the big trauma center, and one is just kind of like our general medical control hospital. Sure. So I called our general medical control hospital. I said, yeah, so he's got a knife in his chest. You know, it's asystole. I believe, as far as I remember, the rhythm was not a viable rhythm. It was asystole. And I said, so he's flatline.
So asystole is flatline,
Yep,
right? Like
he's
there's no
flatline.
heart activity, probably because he stabbed
And again,
himself in it.
this was a long time ago, so it might have been PEA or something like that. I doubt it because there was a knife in the heart, so it doesn't make sense.
But this guy has no pulse.
But yeah,
He stabbed himself in the heart.
You don't have a heart anymore. Like he doesn't have a heart anymore, right? So he's dead. So I called and was like, I need a pronouncement. And she goes, well, how long has he been down for? So I like very much clarified on the radio. I was like, well, he stabbed himself in the heart just like 5 minutes ago. And she's like, well, then you need to work him. It's been too soon.
Okay.
And I'm like very confused. I'm like, how are we even gonna do CPR on this guy? And she was just sort of kind of like figure out and like hunt up on me.
Okay.
So my solution, maybe not the best solution, was like, well, screw that. Like, I'll just call another hospital. So I ended up calling the trauma hospital.
And this is not, like I said, in my mind, this is, and like I said, we'll talk about some of like what the textbook says and what like but taking everything into consideration, you're thinking here, I don't even know how to do CPR on this guy. Even if I did CPR on this guy, how am I going to unsever a heart that's been stabbed?
Yeah.
Like you're seeing, I can see someone who's saying like, if someone got stabbed, and we'll talk about this too, like location, but if someone got like stabbed in the chest with a little knife and also went into cardiac arrest where their heart stopped, could we revive them? Maybe. But this is a scenario where like you're looking at this big knife jammed into someone's heart.
And it's a traumatic arrest. So the rules change now. When there's a traumatic arrest in terms of like, we're going to work this guy for this amount of time, like that sort of thing, things start to shift when you have a traumatic
so your protocols
arrest.
change also
But it's not like he got hit by a car and it's a traumatic arrest. It's like he stabbed himself in the heart and he doesn't have a heart now and it's traumatic arrest. So like, we just don't really, like, we're like, I don't know what to do. So in my mind, I'm like, well, I'm going to call the trauma hospital and just ask them. Hopefully they'll and
see what they'll
have it.
Which makes sense. I mean, there's more of their expertise.
And then I call and I let them know. And they're like, oh, yeah, you can go ahead and pronounce them.
Okay, all right.
But afterwards, with the crew and discussing it with them, like this brought up a lot of like, okay, like
what do you
when
do?
do we work? When do we not work? Like obviously in this situation, it definitely seems like we did the right thing. But I wanted to maybe just talk today about like when we work someone, when we don't work someone, and what constitutes as like a unsalvageable situation.
So there's two questions here that I see, and this is kind of what we wanted to discuss today. There's two questions. The first one is, when do we remove a penetrating object? Right? Like just like baseline, like when do we remove a penetrating object? Can we remove that knife? What if he did have a pulse? That sort of thing. We'll talk about that. The second thing is, do we do CPR in this situation? And when can we terminate CPR? When can we say, basically, you know what? I'm not going to do chest compressions. I'm not going to do CPR on this person anymore. When is it an appropriate time? So those two big questions are, when can we remove an object? Can we remove an object? And when can we or do we terminate CPR?
Right. And as a general rule with penetrating objects, we learned this in basic, we don't remove penetrating objects, because if we take that object out, what's going to happen? We're going to increase the amount of trauma and external bleeding, right?
Yeah, so let's take it back to basics, right? So you're correct. So the textbook answer is, on one hand, you never remove a penetrating object. Let's talk about why that is, though, right? And I think you're alluding to that already a little bit, that like, one, we can do more damage, right? Two, sometimes that penetrating object is actually keeping that person, quote unquote, stable. And if we removed it, we're going to make things worse. Does that make sense? So like in my mind, let's take this situation out. Let's just talk about penetrating objects in general. If you've got a knife or something, you're in an accident, there's something stabbed into your stomach, right? That object is in some ways stopping bleeding. It may have severed some vessels that are bleeding, but sometimes that can be stuck in an area where it's preventing worse bleeding internally. If we remove that, now there's nothing blocking those vessels from just bleeding everywhere. So that's one of the reasons we don't remove a penetrating object.
The object is essentially acting as a clotting agent or clotting object. It's blocking the flow of blood from exsanguinating or getting out of the body, at least, right? So like, even if there's internal bleeding, I'd rather have internal bleeding than I'd have external bleeding. So that object is acting almost as like a clot, just like we would if we had like a hole, a gaping hole. We'd pack that wound. Well, the object is already packing the wound that it created. So removing the object is going to result in a more difficult healing situation.
Exactly. So, and that's the thing too. So our body is created in a way where, like I said, if you start bleeding inside, there are like, organs and tissue that like kind of keep that bleeding in certain areas, for the most part in different areas. But like you said, if we take an object out, now there's a track to go out. Now there's nothing, then like I said, out in the world is as big as it can be, right? So we can just now have, so that's one of the reasons we don't remove a penetrating object, right? It causes that external bleeding, and it can, again, remove an object that might be preventing some bleeding that could have occurred, right?
And another reason that we've been told not to remove objects, we don't know if that object is in pieces. We don't know if that object, so we might not be truly removing the object. We might be breaking that apart as we pull it out. Something like in a situation of like a wood chipper or something, if something stabbed into them and I pull that out, but I leave splinters inside, we need to rely on more advanced medical personnel to kind of analyze that situation to make sure they get all of it out. So we're not really even necessarily accomplishing what we want when we pull the object out in the first place.
Okay, so back to basics. Again, we're going to keep doing this. So back to basics, we don't remove a penetrating object. Now, of course, in a minute, we're going to talk about when you might. But let's say for the general rule, we don't remove a penetrating object. So let's say this guy had a pulse. All right, so for the sake of argument, I'll play a little bit of devil's advocate here. He's got a pulse. How do you treat someone? And again, going back to basics, how do you treat someone with a penetrating object? We're not going to remove it. We've decided that. That's what we've been told. And we know why. What would we do? What would you do? He's got a pulse in this situation. Let's say he's got a pulse. He's got a penetrating object. What do you do?
So you got an object. The fear here is it creating more trauma by moving around in there. Mm-hmm. So our main priority is to stabilize that object and then stabilize his vital signs by other means. So I would take like rolled gauze or bulky dressings, and I would pack around that object to make sure that object's staying still in the chest. And then I would wrap that real tight so that it can't move at all. So we're not creating more trauma with that, that knife wiggling around in there, whatever it is, wiggling around in there. And then I would work on basic trauma treatment, right? I would work on fluid. I would work on stabilizing blood pressure and making sure that his airway is patent, those sort of things.
And this is what we do in the emergency department too. I mean, so even in the emergency department, I don't remove, for the most part, I don't remove penetrating objects. Large ones. I mean, like if it's a small object and I have the means, and some of it is what tools do you have? Like I have more tools I can cauterize, I can do certain things in the emergency department. But if it's a large object that's in like a stomach, a chest, I'm not going to remove it either. We're going to keep that thing nice and stabilized. We're going to try to get an assessment, maybe do some imaging if we can to figure out where exactly that is, if the person's stable enough. But that patient needs to go to an operating room. They need to go somewhere where a surgeon can go in and clip vessels and cauterize things and stop all that bleeding that we're talking about. So good. So again, like I said, that we're trying to avoid that object from moving around inside and causing more damage. So we're going to stabilize that thing. So again, we're not going to remove penetrating objects. Penetrating objects are going to be stabilized so that they don't cause more damage. Seems pretty straightforward until the person has a knife in their chest and they don't have a pulse.
Right. So if we went back to he doesn't have a pulse, there's an object in my way, but it hasn't imploded his heart, my thought process then is, okay, is it going to cause more trauma when I pull this object out? Absolutely, but he's dead. This is a life and death situation here, right? He's dead. We need to get a pulse back. That's our 100% priority, right, with a CPR. So we're going to go ahead and remove that object and start doing CPR. So if we have someone who, had even a knife just a couple inches to the right or left in the center of his chest, something like that, I can't get a good hand position to do CPR. Well, then I go ahead and remove that object. I'd pack it as best I could. I packed the wound as best I could, or just direct pressure, right? And then we'd start doing the best CPR we could. Now, granted, is the case gonna go well? Probably not, but we have to do the best we got with what we got, right? So what was so unique about this case, though, is that the knife was 100% in the heart.
So that's another question I want to pose. So again, textbook, and what's funny is I actually saw this question asked on a student forum, an EMS student forum. It was literally like a question like this, like patient's got something stabbed in their chest, they don't have a pulse, what do you do? And the textbook answer was to remove that object and to start doing CPR, right? That's the textbook answer. That makes sense. We're talking about, like I said, the only two times you can remove a penetrating object is if it's impeding CPR or it's impeding your airway. Like if airway and breathing and circulation, those are the most important things. Those are the only two times. So like a situation I think in my head, like, okay, let's say this person had been in a terrible car accident. You get on scene, you see something impaled like, into the right side of their chest or in the mid-sternum, and they don't have a pulse, and you don't really know what caused that cardiac. Was it that penetrating object? Was it blunt force with the steering wheel? That might be a situation where you remove that object and you start doing CPR. Again, is it going to be a good outcome? Probably not.
Well, traumas aren't usually, right? A traumatic arrests, we usually don't have the best outcomes for. These are the toughest cases. These are the hardest ways that we have to bring someone back.
Right, exactly. So, but again, this is a different situation. So this is someone who's taken a knife. The only trauma they have is the knife straight into their heart, which clearly is what caused the
It's
not beating.
It's not he's a CPR patient and he has a penetrating object. He's dead because there's a penetrating object. I would equate this to, like, if we want to look on the airway side of things, like if someone was like jousting and the lance went through their throat, right? They're like, you get on scene and they're clearly dead because they're non-recoverable, right? That's one of the reasons, and we'll talk in a different podcast about when you can halt resuscitation and stuff like that. But one of the ways that we can halt resuscitation is when there's obviously no chance of bringing them back because of the situation, right? Like a decapitation or something like that, right? So this lance is through someone's throat, right? It's like completely through them. You're not going to be like, okay, let's take that out and start bagging them through this giant now stoma of a hole in the neck. Like that's just not something that's going to happen. So that's how we pegged it. And obviously, the first hospital I talked to, maybe I probably didn't describe the situation as best as I could. Maybe I should spend more time on the phone with them, but they didn't see it that way.
So the other thing, the last piece here I want to talk about is why we need to remove an object. So like I said, on one hand, we say you can never remove a penetrating object, which is true, except there's one or two cases, right? It's impeding CPR or it's impeding the airway. Why in those situations do we need to remove? Why can't we? Why would you not just leave that in place? And like that one doctor was doing, try to do CPR around it. Does that make sense?
Sure. I would say you're causing more trauma then. Right. So our job is first and foremost not to do more harm, right? Like that's the Hippocratic oath. Like we're not going to do any more harm than we can. And with a penetrating object, if I'm doing CPR around it, well, it's essentially like I'm stabbing this guy over and over again, right? So we can't do that. The reason we don't pull an object out is the same thing. It will do more harm than what's currently going on. But if the difference is, this is an answer that we get a lot of questions on the forums like this where people get tripped up on National Registry questions where they say they present you with like a traumatic place or traumatic case. Maybe they give you like a semi-serious bleed, and then they say, but it's a CPR situation, no pulse, and they say, what do you do first? And the answer is going to be do CPR, even though they have this bleed, and they go, well, wait a minute, I thought serious bleeding, that's a priority up there too with circulation. Well, yes, but they're dead. Like when someone is dead, when someone does not have a pulse, all that we can do is CPR. That is what we will do. We'll solve all that other situation later, right? I say in my CPR classes all the time, like, It does not matter how they died. It doesn't matter if their arm got chopped off, if they got hit by a car, if they froze to death, but they are dead. And now our job is to do CPR on them. Once we get a pulse back, now we have a patient, right? Right now, unfortunately, we have a cadaver.
Right.
If we can turn that cadaver into a patient, then we can treat those patients sometimes very serious issues like a major bleed. Now, thinking practically, if you and I are in the back of an ambulance and I see someone with a major bleed and they don't have a pulse, well, I got two sets of hands here, right? I can start doing CPR. You can pack that bleed. We can try to handle the bleed at the same time. But test question wise, the priority is always going to be to do CPR on someone who doesn't have a pulse.
And I would say too, I mean, even for people who are not trained medically at all, obviously, like we teach CPR classes as part of our training center. We encourage that, to lay people and to people who are not in medicine. Like, you can't do any more harm to someone who's dead. You know what I mean? They don't have a pulse. I mean, doing chest compressions, doing CPR is the best thing that you can possibly do. So there's never if a patient doesn't have a pulse, if a person doesn't have a pulse, if a family member doesn't have a pulse, it's never the wrong answer to start doing chest compressions.
Absolutely.
Right? Every single time.
Correct.
So the other thing I was going to mention too, in terms of like why do we remove that object, is that not only, like I said, again, are you stabbing that person up and down as you do chest compressions, right? But also, like, you can harm yourself. You've got a big knife there. You're trying to, you can just cut
it's a
your
weapon
hand
on
off,
scene.
right?
Yeah.
And then all of a sudden you've got two patients. So again, you need to be cognizant of that as well. You don't want to put yourself in harm's way. Which brings me to then, when can we terminate CPR? So when can we say, you know what, we're not going to do CPR, or we can be done doing CPR? And that's one of them, right? If you're ever in a situation where it's become dangerous to you to continue with treatment, to continue CPR, that is a perfectly appropriate situation to say, you know what, I'm not going to do this.
That goes
right?
back to basics. Scene safety is always your priority. That's another thing we teach in CPR classes is your priority isn't the patient. Your first priority isn't the patient. Your first priority is not your team. Your first priority is yourself. Your second priority is your team.
Yeah.
Your third priority is that patient. Because unfortunately, it is not your emergency, and that patient is dead. When we look at our save rates, like, don't become another victim. It's not worth doing that, right?
When else would you say is an appropriate time to terminate CPR?
Yeah, so if we have, like I mentioned earlier, like that futility of care, right? There's no point in continuing because the patient is not viable. And this would be a situation in which it would not matter if we did the most amount of interventions that we can do. We'd at that point just be putting the body through a bunch of nonsense, right? So something like a decapitation, something like a stabbed in the heart, an exploded heart, right? Something like major organs just gone.
Yeah, if the person's liver is like next door,
right. And this is
why
people kind of mix this up, but this is why, like, when we arrive on scene and we pronounce someone versus working them because they've been down for multiple days or so many hours, we're looking for signs of futility of care. Like, if they have independent lividity where they have pooling of blood in areas, their pupils are fixed and dilated, they're cold to the touch, like, that tells us that this body has been shut down, and rigor mortis, right?
Yeah.
At different times. And this body is completely shut down. There's pooling of blood now. Like, I can't now pick that blood up. It's toxic now. I can't pick that blood up, circulate around it, and I'm not a necromancer, right? Right? I'm a paramedic, so I can bring someone back from the cusp. But you can't just reanimate someone, right? So,
and this is kind of, I think, what the initial the first hospital, they clearly didn't understand exactly like this mechanism, but that was their first thought, right? If it's only been 5 minutes, are we still on that cusp? Do we still have time? And in this case, no. But again, and as I think the textbook says, like, signs of irreversible death, which is like rigor mortis, that like dependent blood pooling. Someone's cold, they've been down for a really, really long time. I mean, if you don't know how long they've been down for and you're not sure if they have those signs, well, then try to do CPR, right? I mean, these are the kind of things. So
when we do work someone, we work them for usually a time frame per protocol, depending on where you're at. You might have a time frame of 30 minutes or 40 minutes of where it's necessary for you to work before you can start considering futility of care and say, no, we've done everything we can and it's just not happening. But we had a case very recently where we had someone who was in persistent ventricular fibrillation, so a shockable rhythm where their heart has electricity moving through it, and it was persisting for 45 minutes. And normally on a call, like if we had an asystole, a flat line, 45 minutes of trying to resuscitate them with no dice, we're usually going to call them. But with this viable rhythm where we can shock this, we might be able to, their heart's trying.
Right.
That changes the game completely, right? So the crew recognized that and transported to the hospital, and they burned through their whole drug box, gave everything that they could give, and then continued to transport, even though the patient was technically still dead. There was still a chance of survival, right?
Yeah.
So, like you said, it's got to be no chance of survival, complete futility of care. In my book, this stabbing that's what that was. I think most medical providers would have agreed with me. They've been on scene and been looking at it. But that's where, communicating effectively in your radio report, I'm sure I was shooken up. I was shooken up from the previous call, and now with this one, I'm working on this guy. This guy was like way younger than we expected. It was upsetting, right? So I'm sure I was shooken up and probably rapidly just being like, there's a knife in his chest and he's dead, pronounce him kind of thing,
Right. It's not a pocket knife sitting
right
here.
Yeah, it's like a machete size.
Right.
It was like a chef's knife. So I probably just kind of jumbled, went too quick, and created a situation for myself that wasn't going to work out.
Awesome. Cool. Well, I think that pretty much sums it up. So really quick, again, back to basics. The big things we want to pull away here is, one, as a general rule, we're not going to remove any penetrating object. What we're going to do is we're going to stabilize that so it doesn't cause more harm. The only times that we would ever consider removing a penetrating object is if it's impeding CPR or it's impeding an airway, right? And then going back to that CPR piece, when can we terminate CPR? We can terminate CPR if we're ever in harm's way as the rescuer, as the provider. We can terminate CPR if there's futility of care in the sense that there's signs of irreversible death. We can terminate care based on our protocols. I mean, if our protocols and things say, hey, we're going to go for 30, 40 minutes, that's based on research that says once you've gotten to that point, the person's not going to survive really any chance. So we can stop there. Or we can stop, obviously, if we get pulses back, right? So those are those big things there. So I appreciate you sharing that case with us. For our listeners, again, thank you so much for taking the time. This is episode 1, so I might be talking to no one.
Inaugural.
Right, yeah, the Inaugural podcast. So appreciate you taking the time to listen. We've got more coming for you every week. Please, again, follow us on your, however you like to stream podcasts. Check us out on Facebook, Instagram. Check out our website. We'd love to get involved and hear from you. So thank you so much, and we'll sign off.
Stay sweet. Hey guys, hope you enjoyed the episode. If you're an EMT or medic student, or an advanced EMT student, or an instructor of those students, we have a program just for you. With Seitz and Sirens Nremt prep program, you get video lectures, over 15 hours of really vetted, great content to help you through your program and help you prepare for the test. Check it out at www.seitsandsirens.com.